Thank you, Dr. Atticon. I think it's a little difficult to talk about. Yeah, this was fun. It's a little difficult to talk about our findings from a study that's been funded now for a couple of years because we've been unable to start the study. But we will start in January. So I wanted to put into context what I was saying earlier in the welcoming about where we are and where I think we can go. You know, I'm Guyanese in my heart, but I'm not Guyanese. You're Guyanese. This is your country. The Global Psychiatric Epidemiology Group, we do work around the world, and we have focused on Guyana because it is such an interesting, wonderful country. We're here to help. We in no way can decide what you should do or how you should do it. But we do have certain kinds of experiences and expertise, and we want to bring those, and you can use them as you will. That's your choice. But we as a group have come to love this country. And I want to talk about how it fits in the world of suicide and try to get you to realize what you can do, what we can do together to move it forward and to get it away from this plague. So I want to talk about suicide in a global context. So here's a very nice map of the world, and you can see those very dark shades. They're very few and far between, although of course Russia is very large, but you see there's our beautiful little Guyana, Suriname, Uruguay. But the rest of the world, for the most part, doesn't have the rates of Guyana. So the question we have to keep asking ourselves is why? What is going on in Guyana? Why does suicide have the grip on this population? And how can we change it? It's a very simple question, but we have to figure it out. So again, look, thinking about the world, 700,000 people die every year from suicide. That's one person every 40 seconds. It's the 18th leading cause of death, but in the US, it's the 10th, right? It's the 10th in the US, but it's the 4th leading cause of death in the world in 15 to 19-year-olds. The real number we know everywhere is higher. So when we say that Guyana is sometimes it's the first, second, third, it doesn't really matter, it's way up there. When we say that number about Guyana, you have to know it's worse. It's higher, okay? It's hidden for lots of reasons. Traffic accidents. I'm going to show you about traffic accidents. Religious beliefs, misclassification, right? Many religions, you can't be buried in the cemetery. So you died of natural causes rather than suicide. It's a cultural phenomenon that we hide cases, meaning that it's worse. Every death matters. 70%, 77% of all deaths are in low and middle income countries. And we also know that at least 20 attempts for every completed suicide. Every single attempt is a traumatic experience for that person and frequently the person in their life. So when you think about the horrible rates of suicide, you have to think about how that gets expanded many times over. Young persons globally. Young persons committing suicide in Guyana is a big problem. Globally, it's the second leading cause of death in 15 to 29-year-olds, 8.5% of all deaths. So you can see here the crude rates of suicide per 100,000, 15 to 29-year-olds. Look at France, 5.2. Korea, 16.9. Terrible. Russia, 19.5. Poor. Terrible. But look at Guyana. Why? Why do we have 58.2%? Why? Not percent, but number. Why? That's what we have to find out. Why? So we can do something about it. But the other thing that we also know about suicide, everywhere in the world, it's not equally distributed. It's not equally distributed. If you're poor, if you're deprived, if you're disadvantaged one way or another, your risk goes up. There are gender differences. Many years we talked about men had the highest rates of suicide, women much, much less. Well, we now know a lot more about that. It's not exactly correct. It's different in different countries. And when we talk about cases being hidden, who's more likely to be hidden? Females. So anything that we do and anything that is being done almost always fails to address this unequal distribution. When we develop intervention programs, where are those intervention programs? They're frequently among the more affluent. If we put in a hotline, who knows to use the hotline if we don't do our homework and make sure that everyone knows how to use the hotline? So you end up, even with the best of intentions, by putting in interventions, creating further inequality in an unequal distribution. CARICOM, you're all here in Guyana very much familiar. You're part of CARICOM. You know all of these countries. These are your neighbors. How do you look compared to your neighbors? How do you look in terms of the group that you most fervently associate with? Well, here's how you look. Not good. Not good. Suicide mortality rate by year in the CARICOM members, 2009 to 2019. Look at who's on the top. Guyana and Suriname. On the top, all those countries in CARICOM. You don't look good. You gotta look better. We gotta do better. Ages 15 to 29, crude suicide rates, CARICOM countries. Look at those numbers. Look where Guyana stands. It doesn't have to look like that. Look at Suriname, second highest, but look at how different it is. Look at the world average on the far right. Guyana. What does Guyana look like? When we talk about all these other things that may in fact be associated with suicide, and why do we just start a program at the University of Guyana in injury prevention? Why? As a suicidologist, what am I doing with the Center on Injury Prevention? Well, because I believe, and I think the data bears it out, that that's a back way into suicide. And here, look at these data. Look at this. 5 to 14-year-olds. Look where Guyana is, on the bottom. On the bottom. This is South America. This is not CARICOM. This is South America. And you are on the bottom. You see, can you read that list on the right? Transport injuries, car accidents, unintended injuries, self-harm and violence. That's how it gets classified in the emergency room when the body comes in from a car accident, from a fall. It gets classified this way, not as a suicide. But you can be sure many of those cases are suicide. So again, the numbers are worse than we know. But why is Guyana on the bottom? Here's South America again, 10 to 24-year-olds. Who's on the bottom? Why? Here are the death rates. Who's on the bottom? Guyana. Again, transport accidents, injuries, unintentional injuries, self-harm and violence. Guyana's on the bottom. Those activities are highly, highly correlated with suicide. If we can make dents in those things, we can make dents in suicide. So when we talk about what can we do, we can do a lot of things. We can do it from a multifaceted perspective because suicide is multifaceted. Everyone that kills themselves is different, and they have a range of activities and a range of attitudes and beliefs that bring them to that point. We can intersect with those attitudes and beliefs if we think about it and try. This is cause of lost life years, road injuries, falls, drowning, self-harm, violence, all related to suicide. It doesn't matter how you look at it. It doesn't matter how you look at it. Guyana doesn't look good when it comes to suicide or activities related to suicide. Here's another one, 1024, same thing. Look at how much the proportion of these activities that take up the loss of life. Okay, I don't want to hit you over the head with it, but you've got the idea. Suicide in Guyana. Okay, here's the rates per 100,000. I'm sure all of you know that varies by region. Okay, simple, simple. Okay, here's the rates by year. Look over time, 2009 to 2019. Look at the world. The world is getting slightly better. That slide that I showed you in the beginning when it said 700,000 deaths in a year from suicide, I showed a similar slide for many, many years, and it was 800,000. The world is getting a little better slowly. Guyana is rapidly getting worse. Why? Look at that line, that pink line. Look what it's doing. Suicide in Guyana, these are again crude rates, males, females. Look at the ranking on the right. Males, females, total. Second, worst in the world. This is the crude rate by age. Okay, this is 2020. Not good. It's got, interesting variations across time. We can come up with all kinds of ideas about why that might be true, why it might not be true. Look at the elderly. What are we doing about the elderly? What are we doing about the elderly? And you can be sure that there are a large number of suicides in the elderly that are not counted as suicide. You can be sure of that. Why? Because it's very easy to say natural causes. Who wants to say that their grandmother killed themselves? Nobody died of natural causes. But you can see that there, that 70 plus, how bad it is. What are we doing about the elderly in this country? We can do better. Here, if we look at gender and ethnicity, differences, how real they are. I always say, and the number of epidemiologists in the room, that if we get the real numbers, they're always different than what we thought. Always different. Always different. We don't have those numbers. We're going to get them. We're going to get them. I'll get to that in a minute. This is suicide method. I did a big study in Tajikistan. It's a Muslim country. Most of it is very, very steep cliffs. So I went there and I'm driving through the mountains and I'm thinking people are jumping off the cliffs and I'm thinking about how I'm going to arrange to get barriers put on some popular jumping points. Completely wrong. Completely wrong. Everybody in Tajikistan's hanging themselves. Why? I don't know. They put barriers up on the Golden Gate Bridge. People travel over the other bridges to get there to kill themselves. There are places and methods that people use. We have to know why it becomes a grip on populations. And then we have to figure out how to change it. So when I said earlier about change individual behavior, that's what I'm talking about. We gotta help people to change their behavior. So religion, lots of talk about religion. We always think of religion as a protective factor, and yet we have varying rates of suicide by religion. What does it mean? What does it mean? We have to figure it out. We have to figure it out. This is a very interesting slide when you think about what I call fluidity, and that is people's changing from one religion to another. And I am struck by the ease with which it appears to me, and I could be, again, completely wrong. I've been wrong most of the time in my life. But I do find it very interesting how people change religion in Guyana. I was talking to a man just recently who was a Guyanese working doing some painting in our offices, and I know his brother. Brother's a religious Hindu, and he was telling me that he had almost killed himself, but then he didn't. And anyway, we kept talking, and then he said, I said, are you religious? And he said, well, yeah. He said, no, I'm a Christian. And I said, a Christian? I said, what happened to being a Hindu? His brother's a very religious Hindu. He said, oh, he said, I'm now with a different woman. She's a Christian, so I'm a Christian. And it struck me. You know, this is a kind of fluidity that you don't usually see. But I've had lots of conversations with Guyanese, similar kinds of fluidity in the way that they move. Is that really a problem? I don't know. I don't know. I don't know. But it could be. But I think this particular slide is very interesting. Very interesting. So, what are we doing? What am I talking about this study? Well, the name of this study is Uncovering the Risk Architecture. Architecture because I don't think it's any straight unidimensional aspect. I think it's multidimensional. And so architecture is a very good way, I think, of capturing that concept. The objective of that study is to just go beyond the traditional research of suicide risk factors. As I said earlier, we can do all the wonderful little studies we want, big studies, but if they're not thought out and they don't capture what needs to be captured, they're for naught. You're wasting your time. We know all about the risk factors. I just showed you the risk factors. That's not going to help us solve the problem. We have to figure out the big picture and how these things go together to create suicidal behavior. That's the challenge. So we're doing lots of unique things in terms of, the heterogeneity of the known risk factors, the consideration of all three levels, the individual, the community risk factors. There are many unique aspects of this study, but the important thing about this study is that it's comprehensive. And as I talked, suicide is multidimensional. So just so that you understand who we are as the Psychiatric Epidemiology Group, it's a global group, and we always take the global life course perspective. And that is, we look at all of these things in every study to the extent possible. A lot of it is unusual. What people do, they do one or two of these things, two or three of these things, but they don't usually do all of them. To the extent possible, we always try to do all. Our methodological approach, we are a global psychiatric epidemiology group. Epidemiology is a driving force. So these are the things we believe give us good data. Representative sampling, I'm going to talk about the national study, matched controls, longitudinal design, a developmental focus. How is it that a 14-year-old is thinking about suicide? What has happened in the first 13 years that you get to be a 14-year-old thinking of suicide? You can't ask that question only of a 14-year-old. You have to understand what happened in the first 13 years. How did that child in that family get to think of killing themselves? And that means also the inclusion of family members, but it also means the context. Context matters. You can't say that it matters if you have poverty and then you don't think about what are the effects of the poverty. You have to look at it. It's context. So we are very fortunate in this study, which is an NIMH, National Institute of Mental Health study. These are our partners, and I am very pleased and proud. Some people are on the Zoom right now. Some people are in the room, but you cannot do this work. You cannot take a comprehensive approach if you don't have collaboration and input from people who have a different perspective than you have. That's required. So this is the study, the first study that we're doing. It's called the Guyana Well-Being Study, which is part of why this is called the Well-Being Conference. There are 3 parts of the study. The first is a national representative community cohort. It's 5,000 people. It's being done throughout the country. It will be nationally representative. 5,000 people ages 15 and over. It will be longitudinal. There will be 2 follow-ups. So there's a lot of unusual things about that. First of all, it's nationally representative. That's very unusual for a suicide study. It's going to be longitudinal, very unusual for a suicide study. And that it goes all the way down to age 15 and up. So those elderly people that we talked about, they are in the study too. The second study is a clinical attempters sample. And there it's every person who comes in to one of the crisis clinics will be assessed. And the assessment of that group will be almost identical to the national representative sample. So we can begin to tease out who is coming into these clinics and how do they compare to the community sample, like controls, okay? And the third one is a survivor sample. That is a loved one, a mother, a father, a sibling, a spouse of a person who died by suicide. We are going to interview that person and one other person, 2 people who are closely aligned with that person who died. There are problems with this study. I start at the bottom. When we talk about the survivor sample, we could only afford to do 5 of the 10 regions, and we could not afford to do it longitudinally. That's a problem. I'm trying to solve that problem by getting additional funds, but at the moment, we don't have it. So that's a problem. The attempter sample, although it is national, it is not longitudinal. That's a problem. I'm trying to solve that problem. So that is the study. You see on the bottom, we're collecting saliva, and we're doing that with Professor Cummings, and there's actually a couple of talks at the conference here on genetics and mental health. That's one of the things we're trying to do. We're not funded to process that, but we're collecting it. We always like to invest. So we invest in the samples and then try to get somebody to pay to process. That's just what you have to do in science. You can't always get something funded, but if you don't start, you don't finish. So it's just like I said this morning, if we don't start the process of trying to really attack the plague of suicide in Guyana, we're not going to get there. We have to start, right? This is what this is going to do. It's going to start. So that's the study with the Ministry of Health. And now the study that we're also doing is the injury and trauma training program that we're doing with the University of Guyana. And those 2 projects, the well-being study and the training program, actually is what we end up calling the Guyana Well-Being Projects. We expect that there will be numerous other projects coming on board that fit with the agenda of these 2. This is the program leadership. For those of you who know these people, they are all outstanding leaders in your country and at Columbia University. And the center at Columbia University is a large CDC center that is for injury prevention, and we made ourselves the sister center, not the brother center, but the sister center. Power is with the sisters. So we made it a sister center. And as you can see here, one of the things that we will be doing is the co-mentoring with the faculty here and the faculty at Columbia. We will having sharing resources. And again, funds are always limited. So one of the things we are trying to do is to get additional funds so that we can pay more students to get their advanced degrees. And we are working with the University of Guyana to get people certificates from Columbia University, Mailman School of Public Health. That is part of what we are doing, but we want to expand that activity. Just to give you a clearer idea of who's involved and how extensive this training program is, you can see at Columbia University the different departments where the faculty involved in this center are coming from. Similarly, you can see how extensive the involvement is at the University of Guyana. You can also see the hospital corporation. And the hospital corporation is very critical to this work, which is not only injury prevention, but again, it is suicide. We are trying to understand suicide. And so the hospital corporation, we are part of the work that we are doing there will be in the emergency room and with the training of residents so that we can begin to understand that part of the process of people committing suicide, coming in with suicidal behaviors, and how can we best intervene. And then, of course, there's the government of Guyana, which has been particularly helpful and supportive of this work. And it's a great opportunity for the collaboration. And there you can see the ministries that are part of this. So we call it the GRITT. It's I think this final model here will show you what we're doing with a very limited amount of money. Medical residents, we will have 2 trainees annually. The certificate-led trainees, there will be 3 trainees who will be in the certificate program. The master level trainees, there'll be 3 annually. And the advanced healthcare professionals, there'll be 2 trainees annually. And it's it's our intention to use this Fogarty money to support the education and training of Guyanese, so that the Guyanese, this can all become Guyanese. You know, this research that we're starting, when I say it's day one, it's day one, but it's your day one. It's not my day one, it's your day one. And the work should go on. And in order for it to go on, we have to collaborate and train people together so that people can take over. You have a fantastic university. You have a fantastic Ministry of Health. It's you know, people say, why are you so excited about Guyana? I can tell you I'm excited about Guyana, not only because you have such a challenging problem. I mean, I've been doing this work all over the world for many years. But I find Guyana to be a particularly wonderful, wonderful place to work. And one of the reasons it's wonderful to work here is because of the infrastructure that you have. You can't do this work if you don't have the proper collaboration and support. So the problem is great, but the opportunity is marvelous. And it's marvelous because of the people. So it's a pleasure all around. I thank you very much.